Hi everyone, I'm Niharika, and today we'll be talking about how implementation of tele-ICUs in rural and remote areas is helping fight COVID-19. So, as we know, every year 5 million patients require ICU care, and there are around 70,000 ICU beds, and less than 15% of ICUs have access to dedicated specialists. So, tele-ICU is helping lowering down the risk of healthcare workers and provide effective medical care to the patients by providing 24/7 care during COVID-19 in remote and rural areas. So today we have Dr. Dileep Raman, who is the co-founder of Cloudphysician, and Cloudphysician is addressing the critical care shortage by providing tele-ICU service in India. We also have Ratna Mehta from the Vadhvani group, who has extended their support in implementing the tele-ICUs along with Cloudphysician by providing quality critical care. So we can start today's conversation and find out how they are changing India's healthcare landscape. So Dr. Dileep, we can start with you. So my first question to you would be, what was the gap or challenge that has been addressed through tele-ICU during this pandemic?
Thank you, Niharika, for that question. So in some ways, you already alluded to the gap. Now, the numbers that you quoted, about 70 to 80,000 ICU beds, are in the government hospitals. The unaccounted sector that is in the private sector is quite a bit larger. The main problem here in India is that the exact count of the ICU beds is not clearly quantified. But the best estimations range from between 2.5 to 3 lakh ICU beds in India. And these estimates are based on how ICU equipment has been sold all over the country. And I think it's pretty close to the ballpark. Now, that is the size of the ICU bed presence right now in India. Now, the ICU specialist problem statement is a completely different one. And that has to do with, again, something that you already hinted. Most ICUs in India are either run by physicians, which is medical practitioners with a degree in general medicine, or by anesthesia practitioners who have a degree in anesthesia, because anesthesia is sort of a stepping stone to become an ICU specialist in many countries. But that is not an ICU specialist. An ICU specialist is someone who has dedicated training in the ICU after their post-graduation degree. So what that means is you do 5 years of MBBS, 5.5 years, then you do 3 years of any post-graduation like medicine or anesthesia. And after that, you have to do 2 to 3 years of dedicated ICU training. That's what happens in a well-developed medical system, say in the UK or the US or anywhere in Europe or Australia, where you have to have dedicated ICU training. Now, those experts in the country are probably less than 5,000 at last count. So we counted all the training programs that exist in India, multiplied them by the course duration, and sort of arrived at this number. We've looked at all the best case scenarios of trained ICU specialists, and that's the number you come to. So that is simply woefully inadequate for running the ICU beds that we have in India. As an example, when a typical ICU doctor rounds in, say, the US or in India, one doctor would be able to go and take care of 10 to 15 patients. Beyond that, it becomes a little bit hard to keep track of how things are going. And in some places in Germany, for example, they don't take care of more than 6 to 8 ICU patients per consultant. And here we are with a constraint where we need to cover so many more beds than there will ever be enough consultants to cover. Even if you have training programs, it'll probably take 20 to 25 years for these programs to catch up with the actual requirement of ICU specialists. So the best go-between that we have right now is to maybe use some form of technology as a force multiplier, where you have ICU specialists sitting in command centers that are staffed by nurses and ICU doctors 24/7. And then they connect to these remote sites where they have the duty doctors or physicians or anesthesiologists who we can help minute to minute by providing ICU expertise. So they would still do all the routine care that they would be doing regardless at the bedside. But to make sure that they have critical care expertise, that's where the tele-ICU team comes into play. So you're using the most significant part of the intensivist time, which is to provide just critical care expertise, condensing that into actionable inputs that we give to the bedside team. That's an efficiency improvement. So what that does is one ICU doctor is now able to give their inputs to 60 to 80 patients in conjunction with the bedside team, significantly augmenting their bedside ability to take care of ICU patients. So to conclude this sort of an introduction, I would say that in the last 30 years, the most important intervention that improves quality of ICU care is not a device or a technology, it is access to trained critical care personnel, both nurses and doctors. And the COVID pandemic has been a revelation in that front, because even now we're realizing that all the medications and the technology pieces that people were doing research on haven't made a massive impact in terms of saving lives in the ICU. So be it fancy and expensive drugs like tocilizumab or remdesivir, which we hear about in the news all the time, their mortality benefit has not been that great. But what is still a massive requirement is critical care nursing and critical care expertise that is needed at the bedside. So it's just been a very eye-opening experience for everyone who is in healthcare, and also people who are not in healthcare watching from the sidelines, that really the system depends on qualified expertise to use these expensive tools. Otherwise, those tools just remain what they are, and don't end up helping the patient. We can delve on these a little bit more in finer detail, I guess, as we have time. But that's the intro that I wanted to share with you.
Okay. So the next question I would like to ask is, how does the Tele-ICU model exactly work?
So what a Tele-ICU model is, it's concentrating expertise in one command center or a hub location and then connecting to multiple spokes. So in that way, it is similar to other hub and spoke models. Tele-ICUs work very differently in India compared to how they operate in say, North America, for example, because Tele-ICUs need to be flexible to what is happening on the ground. If you are designing a Tele-ICU system from scratch for the US, it's unlikely that it would work seamlessly in India. And we have multiple models that actually demonstrate that over the last 10 years or so. So in India, how it would work is, number one, you'll have to look at a technology piece that is flexible and plug and play, designed for places in India in tier 2 and tier 3 cities. Something that is easy to deploy from the end user perspective, is not too tech heavy, because if it is very technology heavy, the costs would be too prohibitive for the end user to take up, and that itself becomes a barrier. So the last thing you want is that your user, which is in a tier 2 or a tier 3 city, would look at the service itself as a barrier. That's the last thing you want. So you'll have to redesign it or reimagine it in a way where the uptake or the barrier to the Tele-ICU services is low. So that's one step. The next thing you would have to do is to make sure that the service that they're getting or the value that they're getting is in tune with what they want. So what they want right now is access to doctors and nurses. So how it would work is, we would have an internet connection that would be the bare bones basic requirement, obviously, that connects the command center, which has a team of doctors and nurses, that talks to the spoke site with teleconferencing solutions, and also has a high definition camera so that they can see the patient. And then they would get data about the patient in real time, either using an app or some sort of a link with their existing healthcare record system. Many of these places don't have electronic health records. So it would be scanned paper reports or scanned lab reports that we would work with. If they have it, that's great, because then you could just plug in, get the data and help them. But in many places in India, they don't have that. So how we function in India is that we have a model that has a low barrier to uptake, and then we have a conduit for the data to come in. And that conduit is a platform that we use, which has an app and a web-based interface. Once the data comes through, we use a teleconferencing solution by which we interact with the doctors, nurses, and even the patients there at the bedside, and impart care to them. Our recommendations are there on the platform. They can either use it as is on the platform, or they can print it out for their hard copy records. So it's sort of a real-time communication of medical information and data that includes video, audio, text, images, and interplay with the platform that enables this care to happen seamlessly.
So, how cost effective is Tele-ICU for hospitals and patients in India?
Okay. In India, it has to be a win-win for everyone, including the patient, the administration side, and the hospital. And thirdly, the clinical care team, which is the physicians and the nurses. So, like we discussed before, most of the critical care is concentrated in metro cities, larger cities. And there, the care ends up being very expensive. So if you're looking at it from a patient standpoint, if the TeleICU system empowers the hospital to take care of that patient in that hospital close to their home in a tier 2 or tier 3 city, the costs remain low. Provided there is no dilution in the level of care, which we would ensure, then it works out well for the patient, because for the same illness, they would be paying maybe 2 or 3 times more if they were to get transported to a metro city. And not just that, they would have to arrange for stay there, accommodation, things moving away from the comfort of their own town adds to the cost. From a hospital administration perspective, they are able to take care of these patients in their own hospital, which they would otherwise be referring. So from their ICU occupancy and ICU efficiency perspective, it's a natural win for them in that regard. Okay. So that's the financial implication for both the hospitals and the patients. And from a physician standpoint, they are able to get a more balanced work-life experience, because we are able to offload a significant amount of their time and energy spent in the ICU, and the same goes for nursing as well.
Okay, great. So Ratna, I would like to ask you, how did you decide to partner with the Tele-ICU initiative for ACT grant?
Thanks a lot, Niharika, and thanks, Dr. Dileep, for the details about Tele-ICU and how it is so very relevant. So I think, if we look at, the Vadhvani Foundation mission, okay, our mission has been to fund innovative healthcare ideas which can create a catalytic impact to improve the public healthcare infrastructure. And what the pandemic has done is brought to the forefront some of the grave issues which the healthcare system has been dealing with, which is shortage of doctors, nurses, and as both of you all have mentioned, critical care staff is in shortage. Beyond the metros, I think it's very difficult to get the right kind of talent. And therefore, it is not only important as a rapid response, but to improve the overall public healthcare infrastructure, to innovate and help solve the problems which are there in the healthcare infrastructure. And I think what Cloudphysician has is a beautiful combination which kind of caters to these things, right? Because in a country like India, where 70% of the population is in the rural areas, it's very difficult to build the public healthcare infrastructure overnight, right? And if we are able to use technology to overcome that problem, I think there is a lot that can be done through the remote ICU monitoring solution. So I think that was one important reason that we wanted to back Cloudphysician. And also, I think this is a great opportunity where there are tailwinds from the healthcare system and the government to increase awareness and increase acceptability of the solution. Because if you want to create a systemic level change and you want to bring about the innovation and firmly establish it over the next couple of years, it becomes very important to leverage this currently, right? And therefore we wanted to back them to say, yes, there is proof of the concept, and then we can run with it and expand it to the entire system. So that was one of the main reasons. The second, I think, if we look at the pandemic itself, there are three main issues which the pandemic has raised, right? One is the shortage of healthcare professionals. Second is that the healthcare professionals, they are at the forefront of the battle, but they are more susceptible to COVID. And the third is even the protective gear that is required for the healthcare workers. It is in short supply. So while the supplies are increasing, you're not able to protect each and every healthcare worker. And a remote monitoring solution, especially for critical care, addresses all of those three problems very beautifully. So whether it is rapid response or it is to create a systemic level change to improve the healthcare infrastructure, I think Cloud Physician is doing a great job. And we really wanted to back them to be able to help improve the public infrastructure, healthcare infrastructure.
Okay, thank you for the information, Ratna. So, what is Vadhvani's role in Tele-ICU program?
So we are funding them from our innovation program, right? And the innovation program, the idea is to back, back companies, back startups, which essentially are creating a catalytic impact. But our whole model is based on partnership. So we are not only providing capital, but we access to the Vadhvani ecosystem, which essentially, consists of thought leadership, strategic and operational interventions, and network access. So, for example, we've been working with Dr. Drew and Dr. Dileep, brainstorming on stuff like, growth strategy. So right now, the whole idea is to build a net around the government hospital systems and establish this concept. But over time, the idea is to take it to private hospitals and expand the network through the proof of concept that we're getting right now. The other thing what we are trying to do is provide access to our network, so connecting them with the hospitals which we've dealt with, which we have in our network through our experts, because we have several experts onboarded in the medical field that could help our portfolios and our investee companies. So that is second. And on the operational fund, it's early days. We've just started working with them. So we'll identify a couple of areas where, they need help. I think recruitment and getting the right kind of talent within the company will also be relevant. And, we could play a vital role over there based on our experience.
Okay. Thank you, Ratna, for the insight. So, Dr. Dileep, my question to you would be, what are the challenges in working in remote locations? Something like internet connectivity, or how open are hospitals and healthcare workers in actually adopting the Tele-ICU services?
Yeah, there have always been challenges in the tele-ICU space, both in mature models and in developing models like in India. Interestingly, internet was thought to be a challenge, but when we got down to doing it and visited these places, we're actually seeing that internet has not been a major challenge. Yes, lines go down every now and then, but overall, the internet framework is possible in which you can actually deliver service. Now, the hospital needs to be aware that if they're placed remotely, there may be some outages that are out of our control. And we are trying to install systems that override that and place redundancies so that this doesn't happen. For example, we are going to a redundant framework where we are adding 4G services to our networks so that there is an increased level of redundancy. But all that put in place, it doesn't even feature in the top 10 of our problem statement when we're evaluating a new client or a new site to deliver tele-ICU services. So internet, thankfully, is not one problem we are dealing with. We do have outages that we take care of, but it hasn't impacted care to a degree where we think it makes the entire process non-viable. That has not happened. With regard to buy-in from healthcare professionals and how they perceive tele-ICU services, this is a global problem because, as you may guess, healthcare workers, doctors and nurses in particular, are not exactly tech savvy all the time. Technology is not a core part of MBBS or medical curriculum. So there is a little bit of apprehension on how that is going to impact the way they work, or is it going to negatively affect how they deal with patients. So we spend a lot of time and effort when we do our deployment, our training, and we indicate that this is a platform that's there to help you. It's created and designed by doctors and nurses, and that goes a long way in making them feel at ease that there are healthcare workers and docs already using this, so it's likely to help them. One strategy that we employ that is probably the right thing to do, is to put the patient at the front and center of your entire vision. So generally, when doctors and nurses see that the TeleICU system is designed to help their own patient achieve better outcomes, over time, those barriers, those boundaries are easy to surmount. Once they see that our recommendations are not taking away their autonomy, but are simply augmenting the level of care that their patients get, and it is in their best interests, things go a lot better and smoother. That sometimes takes a few months or weeks to build in. Generally, when they are more tech savvy and amenable to understanding what we're trying to do, it's just a matter of a couple of weeks before they see the positive outcomes that we can impart. So it's a little bit about making technology a more user friendly so that they see it in a positive light rather than as one extra thing that they need to do. So that kind of plays in with how we design Radar, how we design our platform so that it's more user friendly, where the less you see it as a barrier and the more you see it as an enabling tool, the more likely people are to look at it as a positive change.
Okay, that's nice. So Ratna, I would like to ask you, so what do you feel is currently the need of the hour for fighting COVID-19, and what would be Vadhvani Foundation's vision to fight this pandemic and after that?
Right. So, the Vadhvani Foundation's mission overall has been to accelerate growth in emerging markets, right? And one of the best ways that we think that works is by backing entrepreneurs who in turn are creating large-scale jobs. So our focus segments have always been SMEs and startups. Now, what the pandemic has done, Niharika, is essentially it has really impacted the smaller businesses and the startups to a very large extent, because the threshold for them to be able to sustain is lower than large businesses. And therefore, the Vadhvani Foundation has come up with a 200 crore initiative, which we call the Sahayata Initiative, to help the SMEs and the startups. We're actually doing 3 programs under that. So one program is the Sahayata Stability Program, where we will provide pro bono consulting services to SMEs, where we will bring in an ecosystem of, banks, investors, funders, consultants, government to be able to help them. And as an extension of that, the other program that we have under that is the Innovation Fund, through which we have funded Cloudphysician. And the Innovation Fund, the objective is to support early stage companies and startups who are having innovative ideas. And those ideas which can help improve the long-term public healthcare infrastructure. Right? So one is a rapid response, of course, to be able to fight the pandemic. But second, I think, is if we look beyond that and if we look at the preparedness of the system, that has been very low, right? So the essential thing is to fund long term. Now, if I talk about rapid response, I think there is an ecosystem of stakeholders working in this, right? So for example, there is a government. Then there are private foundations, investors, platforms like ACT. Then there is the healthcare system, and then there are citizens. Until and unless all 4 of them work as a well-oiled machine, I think it's going to be very difficult to fight the current situation. And I think there is a lot of effort that has gone into this. For example, government is working under public-private partnerships with a lot of private platforms. They're doing a lot to increase awareness among the citizens. And I think citizens also need to develop the discipline to be able to, adapt to the new normal, as we all call it. So, that is really going to be the core of, fighting the pandemic, joining hands together, which, all of us have been doing and all of us have been contributing to. And companies like Cloudphysician are really coming forward and, doing some great work to help that happen.
Okay, that's really nice. So I think I don't have any questions from my side, but if you guys would like to add anything or give some interesting insights, that would be great.
Now, I think what I would like to add over here, Tanushree, is that we've been looking at a lot of companies in this space, right? Because suddenly there have been tailwinds, and there are a lot of startups who are doing different things to come forward and help the situation. And what has been unique about Cloud Physician is that it is a great combination of a concept which is in early stage right now, but at the right time to establish itself and then expand, so as to so as to overcome the real challenges of infrastructure that we have in India. One is the concept. Second, I think hugely energetic set of promoters who are like really experienced. So what really helps is that you've done it, been there, and Dr. Dileep and Dr. Dhruv have been together for a while. They have seen it and done it in the advanced countries where the technology is much ahead in terms of the learning curve compared to India. So bringing that knowledge and that expertise and experience to India, coming forward and saying that we will deal with the government and we will work with them to help this. It's been a great effort, and of course it's not been easy. I mean, there have been teething issues, and Dilip can tell you a little about that. But the right team and the right attitude to overcome all of that, and work with multiple stakeholders in the ecosystem to get things moving, I think that's been great feather in the cap for them.
Okay, okay, great. Uh, Dr. Dilip, I would like to ask you if you want to share any patient success story, how Cloud Physician helped save a life during COVID-19.
Yeah, there are a few. COVID-19 generally brings around bad news, but it's not all bad. There are a lot of things that are happening that don't hit the news because, obviously, these things don't grab headlines. But when it comes to the bread and butter operations of what is happening on the ground, there are quite a few wins that we can look back and say, okay, at least we're making some difference here. One of the major concerns with our ICUs, especially in the government sector that we are covering, is that resources are being used in ways that can be used in more efficient ways. So just as an example, most of the government COVID sites, when they initially started, were using oxygen through gas cylinders. Now, if you have domain expertise in the ICU like we would tell you that the COVID ICU might end up using 6 to 8 times more oxygen than a traditional ICU. And you would run out of ICU oxygen if you ran on gas cylinders. And this happened. This happened in quite a few COVID ICUs, and we were able to alert the system and the administration that they need to immediately transition to something that is different, either based on liquid oxygen or something that actually can keep up with the COVID requirement. So if you may remember that there was a fairly well popularized tragedy in Gorakhpur where young kids and patients lost their lives because of inadequate oxygen. This happened maybe a couple of years ago. This is the sort of tragedy that you need to prevent from happening, and COVID would just make it much more likely. And we had sites in our private hospitals. We saw this dip in oxygen. We were able to flag the government centers and tell them that they need to prepare for this. And that doesn't come out as a direct patient saving, but when you look at it on impact, that's system wide, right? So that's one example. Other examples are we had a patient who was in one of our government hospital ICUs and was steadily getting worse. And we knew that this patient probably would not make it because of problems related to his underlying illness. However, there's another side to COVID. The other side to COVID is that family members are distraught. They're not able to take care of them because there are barriers. They can't get into the ICU. There are infection control policies that are preventing access. And the patient himself was getting depressed because it's been weeks since he saw his loved one. Maybe a brief Google Meet call here and there. But there was family all over the world. They had family members in the US, in multiple places in India. What we were able to do is that we used our platform we used our high definition cameras, and we got this entire patient family to actually see this patient on a daily basis through our platform. We gave them updates. We counseled the family members both in the US and India. They realized that they had a team of ICU experts who were taking care of their family members, getting exactly the same drugs they would get if this family member was in the US. And that gave them a lot of confidence. So even if the outcome is not saving a life, it is the entire experience of the ICU stay that needs to live up to what an ICU should look and feel like. So it's not all doom and gloom. You need to walk these families through a very tough path in an ICU. And like Ratna was saying, if you worked in an ICU and you see death all around you, you also learn to look at the silver linings. And every cloud has a silver lining. And in this case, Cloudphysician could help this family through that difficult process. And they were even able to deal with death when it happened, knowing well that they had seen him, they had, had the chance to interact with him. And through this difficult COVID crisis that had befallen the family, they were happy at the end of the entire process. So again, technology doesn't have to be front and center. They don't need bells and whistles. But what we enabled was access. And that access, I think the family was very grateful. And even now they keep in touch with us saying, we're thankful for what you enabled. And that's rewarding.
Okay, that's really nice. Okay, so I guess we are almost done. And I just want to say thank you to both of you for joining us and, sharing your thoughts with us. So great. Have a nice day.
It's a pleasure. Thank you.
Thank
Thank
for
you.
making it happen.
Thank you, Dr. Dileep. Thanks a lot.
Thanks, Ratna. Take care.
Thank you.
Bye, Marika.